context of the situation, these are way above and beyond what would be considered normative in the situation. Examples of things, types of aggression or anger would be things like screaming, kicking and hitting, breaking things, and or threatening to harm either themselves or someone else. And so, particularly we're talking about kids here, and so, our presentation of rage is similar to what it is in adults, but it's often a bit less inhibited. Now, one of the reasons we started sort of down this sort of research is A, there wasn't really a whole lot out there, but B, we actually know a few things about chronic tic disorder, things like Tourette's, and how rage presents in there. And given the high overlap between OCD and chronic tic disorders, it made sense to examine this in the context of an OCD presentation. This has been reported now for over almost 15 years as one of the most problematic features of children with chronic tics presentation, becoming enraged and upset, becoming threatening when their tics were very large and very problematic for them. We found in a study a few years ago that the combination of rage with tic disorder indicated that you had a lot more impairment than you did with chronic tic disorder without any sort of rage aspects to it. And then finally, the comorbidity aspect of tic disorders and OCD seems to be associated with an increased risk of rage problems or anger presentations, regardless of the severity of the tics themselves. So if you have, for example, very low-level tics, but OCD, you're at a much higher risk of having rage attacks, which indicates that, well, the OCD may be playing quite significantly into that, which is one of the ways we want to examine it. And then finally, the symptom severity of those with OCD seems to be greater in people, children with chronic tic disorder and rage versus just having a chronic tic disorder. So again, a number of avenues pointing to the fact that OCD may in fact be quite problematic and associated with the rage more so than just the tics. I'm assuming that everyone here is fairly well versed in what OCD is, given that you're at a talk at 8 a.m. On OCD. But just as a reminder, in case you happen to wander in here by accident, obsessions are these intrusive, unwanted, reoccurring thoughts that are excessive and irrational, right? And tend to be very highly anxiety-provoking for the children and adults with them. Examples of this, of course, are, I touch something and then I have feelings or intrusive thoughts about being contaminated and I'm going to be sick from this. Symmetry, so I touch over here and I have to touch over here. Scrupulosity, religious obsessions, and so forth. The compulsions happen after the obsessions, and these are repetitive behaviors that are intended to reduce that anxiety, lower that anxiety in some way. And of course, these become very highly reinforced as a result of that negative reinforcement. So this would, for example, be, again, I touch something, I have an obsession that I am contaminated in some way, so I'll have to get out something to clean my hands excessively with. Checking things to make sure that they are done properly, quote unquote properly, hoarding behaviors, all these sorts of things. And then family accommodation, which Dr. Geffen will be speaking about quite a bit later, is something that we see in OCD in almost every family. And this accommodation is, I, as a family member, am trying not to make you feel worse. This is a very understandable thing in the context of OCD for family members because, I don't want you to feel bad as my child. And so I'm going to do whatever I think I can do in order to lessen that fear. Now, unfortunately, as Dr. Geffen will talk about quite a bit, what happens is, most of the time, this becomes very negatively reinforcing both for the child and for the family, and in fact seems to be a major cause of these symptoms persisting. So we wanted to examine that in the context of rage attacks. So prior study, there's only one other sort of thing that looked at this, and it was a very small scale or descriptive study, had found that OCD, and in terms of rage attacks, seems to be very context specific. This isn't a generalized thing, it's very context specific. And the contexts are where you're attempting to prevent exposure to some sort of fear of stimuli. So let's say, for example, I'm out in public and I have a contamination issue, and my parents are trying to make me go to a public restroom because I have to urinate, and I have contamination accommodation problems, and so I don't want to do that, and so I might have a rage attack, an anger episode, when I'm trying to be placed in a situation that's going to activate my obsessions. If I fear I'm being able to complete the rituals, or I'm still trying to avoid stimuli, that's another very context-specific thing. And again, these seem to be negatively reinforced, perhaps, in that my behavior removes me from a potentially problematic situation. That makes me more likely in the future then to repeat that behavior. Initially, in this first study, not the study we're talking about today, but sort of a little bit of precursor, a little over a quarter of parents reported some sort of rage episode over the past week. These rage episodes were associated with greater symptom severity in terms of OCD symptoms. Lots of an increase in things like sexual, religious, and aggressive obsessions, checking rituals as a result of that. This initial study found a lower frequency of comorbid tic disorders, which is kind of interesting, and that anxiety, mood, and attentional problems did not seem to actually differ between the groups of those with OCD, rage, and those without. And so for the study that I'm talking about today, was sort of following up an expansion of this. The first thing we wanted to do was try to identify the phenomenology of rage attacks. So in other words, what does this seem to look like? We don't really have any good data showing what it does or does not look like. And then finally, we wanted to examine whether or not the severity of rage would influence obsessive-compulsive symptoms, and then subsequently functional impairment via some sort of family accommodation pathway. So in terms of our participants, there were 86 participants here. In something that's sort of a bit novel for pediatric OCD, where we typically see much higher rates of males, we had 44% of our study being females. Almost entirely a Caucasian white sample, with a small amount of Hispanic and Asian in there as well. How was diagnosis determined? Well, this is a consensus diagnosis between 3 highly trained clinicians, 1 psychiatrist and 2 psychologists. All of the people in the study either had primary or co-primary OCD as their presenting problem. We excluded anyone who had a psychotic disorder or some sort of bipolar problem. So relatively clean sample in terms of that. Now, it certainly wasn't clean in terms of comorbidity, and those of you who work with children and adults with OCD know that comorbidity is extraordinarily high in this population. Overall, we saw that 80% of our subjects had some sort of comorbid problem, the presentation of which was very, very similar to the epidemiological presentations that we see in terms of generalized anxiety, chronic tic disorders being the most frequent co-occurring. Almost half of the sample was taking some sort of psychotropic medication, and these are people who are presenting at a specialty clinic for treatment of OCD. In terms of what we administered to them in order to measure a number of different kinds of symptoms to assist with our study aims, there was the Children's Yale-Brown obsessive-compulsive scale. We administered this to both the parent and the child. This is a pretty common sort of gold standard measure. ROARS, which is something many of you may not be very familiar with. This is the Rage Outburst and Anger Rating Scale. This is something the parent fills out to essentially determine, what's the severity of the anger or the rage episodes. We also looked at items of family accommodation. This is again filled out by the parent. The parent's reporting, I am or am not accommodating these kinds of behaviors in the children. And then finally, the CGI severity, the clinical global impression, in order to have an idea about overall severity levels. For the parent report, we also did what's called the Children's Sheehan Disability Scale. This is a parent report on the amount of disabling symptoms, and then the Rage Attacks Questionnaire. This is a self-report measure, again, of anger. So in terms of our results, what did we see? Well, we saw that over half of our population had had at least one rage attack within the past month. This was compared to the previous study that had found 27% within the past week, so we expanded that, and we had a greater number, which would be expected. Lots of verbal aggression and lots of physical aggression. So verbal aggression would be more similar to things like the threatening, whereas physical aggression would be hitting, biting, things like that. A similar number that had exhibited rage in the past month had exhibited what we call clinically significant rage over the past week. So there wasn't necessarily a difference between month versus week. So again, large amounts of this. The place where this seemed to take, the location where this seemed to take place most was at home, with almost 3/4 of the population reporting home occurrences. Under a quarter reported this happening at school. So this is pretty home context specific. The vast majority of these rage episodes were directed at parents, and primarily at mom. And I'll talk about some potential reasons why that might be here in a little bit. And the other sort of major aspect was in other family members. We didn't see really a whole lot of rage directed at strangers or peer groups. In terms of what would be triggering the rage, the main one was what we call parental limit setting, which is why this is mostly directed towards the parents. The parents are putting some sort of a constraint on whether you can or cannot engage, for example, in a compulsion. Or they're placing the child in a situation in which their anxiety is likely to come up in terms of triggering obsession. And so that makes sense about why this is primarily directed towards the parents. Changes in routines. So for example, we typically go to school in this way, and now we drive a different way to school. Or I told you to expect to do this when you're at home, but then we changed the plans a little bit. And then OCD-related triggers. And this is all very similar to what you in terms of expect from a cognitive behavioral standpoint in terms of what might be able to trigger these rages. Now, interestingly, most of these studies, so a little over 2/3, did not experience either mental or predominatory urges prior to the rage attacks. So again, it was some sort of limit setting. This wasn't a pre-mediated sort of thing. What function did these rage attacks serve? Well, 3/4 reported reduced irritability, and 82% reported that their children were much more calm following a rage attack. Now, in the context of OCD, what this means for us is that these rage attacks, again, are being negatively reinforced by the parents, and so they're serving a purpose for the child, and that purpose is reduction of anxiety. So I'm escaping the situation in which I am typically being caused anxiety. So that's sort of the phenomenological, kind of what it looks like. We also wanted to look at some prediction models. So we used a few bivariate regressions to try and see how predictive was rage severity of a number of various things. So first thing we looked at was rage severity predicting OCD symptom severity, which we found to be quite highly statistically significant. We'll see more about this here in just a second. And then we also looked at rage severity predicting family accommodation. And again, this was quite highly significant. So in other words, these are both very strongly related to each other. But, and here's sort of a little bit bigger question I want to know. Okay, well, so rage is related to severity of symptoms, and rage is related to family accommodation. Okay, well, how are the OCD and family accommodation related within the context of these rage symptoms? And so we ran these bivariate regressions, and what you can see up here is there's a much stronger relationship between rage and family accommodation than there is between rage and OCD severity. And then, subsequently, there's a very strong relationship between family accommodation and OCD severity. So in other words, what seems to be happening is that the rage is increasing the accommodation levels that the family does, which then in turn increases the OCD severity. So this would work out something like this. I have a child with OCD. That child has an obsession, becomes very angry because of a contextual trigger, and then I, as a parent, accommodate those symptoms by trying to remove the child from that situation, or trying to remove that trigger or the stimuli away from the children. And in doing that, which actually reduces that anxiety, I not only reinforce the rage, but I also actually, over the long term, make OCD worse in terms of severity. And this fits within a behavioral model of the treatment of OCD because, obviously what we do in OCD treatment is exposure and response prevention, which is basically stopping the parents from doing any sort of accommodation, and then that makes the symptoms better. So we thought this was very interesting. We also wanted to look in terms of functional impairment, so how are rage and functional impairment related? And again, we found very strong, sort of simple relationships between rage severity and parent-related functional impairment. And and then rage severity and family accommodation. So very similar to what we found in terms of OCD symptoms and family accommodation. But again, what we see is a very similar pattern in that the rage seems to be much more related to the family accommodation, which is then in turn related to impairment. And one of the things that we know from years and years of research is that impairment and OCD severity are very highly linked, which makes sense conceptually. And so what we seem to have going on here is that the rage is predicting, is causing, again, more family accommodation, which is increasing not only symptoms severity, but also the impairment as a result of that. And so, none of this I think is sort of surprising. It fits well within a cognitive behavioral model of obsessive-compulsive disorder. But again, this is something that's never actually been studied. So, what we see as a result of all of this is that rage attacks are extraordinarily common in children with OCD. They are not just compulsive behaviors, but they sort of seem to be something above and beyond compulsive behaviors. Their main function seems to be to decrease anxiety and therefore increase feeling good, because you feel much more calm, less irritable after that. And then we see these taking place primarily, although not exclusively, at home and directed towards the parents. In terms of impairment, yes, we definitely saw that the rage attacks would impact both functional impairment and OCD symptom severity. And that they're doing so via family accommodation. So the rage attacks are causing larger amounts of accommodation in families than we might normally see, which then cause these increases in symptom severity. And these rage attacks tend to then, because they're causing all this accommodation, make people modify both their work and their home lives in order to avoid these aggressive behaviors. And so again, they're being negatively enforced, both for the parents and for the children. And unfortunately, what this seems to do is it seems to actually make the illness itself worse over time. So we're talking about, again, a short-term gain for long-term pain and problems. So what's the implications of this? Well, given that over half of our sample had rage attacks, and these are very, very impairing towards treatment, we may need to start implementing more kinds of parent training interventions, like parent management training for younger children, perhaps PCIT, with the structured work programs for engaging in the exposure test. So just, what this ends up otherwise happening is, it looks like a barroom brawl in terms of trying to do exposure tasks with somebody actively engaging in these kind of rage episodes. Now, there were some limitations to our study, just like there were in all studies. Selection bias, these were people who were coming into a well-known treatment center, primarily Caucasian samples. It was a cross-sectional rather than a longitudinal study design. It'd be very nice to have longitudinal data on this to see, does treatment then cause rage to dissipate? We didn't really look at parental characteristics in terms of parenting style or whether or not they were engaging in specific kinds of authoritative or authoritarian parenting things. We didn't do a structured diagnostic interview. I primarily relied on reports and then clinical impressions. And then we didn't actually use any observational data, which would be very useful in determining sort of the phenomenology of what these look like. So, kind of in conclusion, rage, very, very common problem in children with OCD. Seems to be driving family accommodation, which then results in worse functioning. And we need to then work on some sort of treatment in order to address this sort of complex interaction that we have of rage, accommodation, or parenting, and then OCD. And I think we're planning on taking questions at the end of the symposium as a whole. So if you have questions,